Good afternoon. Thank you all for coming. I know it's getting late in the day. I want to thank the organizers for inviting me, certainly. When they asked what I wanted to speak on, my first thought was to talk about CGRP because that's what everyone talks about these days when it comes to headache. But I thought I would talk about spontaneous intracranial hypotension because that's actually had more of an impact on my day-to-day practice of headache medicine than anything else has in the last year or two. It's been striking to me how many of the most difficult patients we have and have carried a diagnosis of chronic migraine for 10, 20 years, when you start talking to them and nothing has worked and they've tried a lot of things and you revisit the diagnosis, you dig a little deeper and you discover many of these patients, in our clinic, a significant enough number that we've actually started a intracranial hypotension clinic within our headache program. We're that busy with patients who have spontaneous leaks. So let me just tell you about a patient that I saw, and it's not a particularly unique patient. She came to us by referral. She'd been seen by several headache specialists. She'd had chronic migraine for about 20 years. She had been on just everything you can imagine. Her headache was not obviously positional. She was complaining mostly of an occipital headache. She noted that she had had episodic migraine in the past. She also had some mid-scapular back pain, and she had some persistent tinnitus. Not untypical of many patients, I'm sure we all see, these very difficult patients. Obviously Ehlers-Danlos, but she was pretty flexy. She could put her palms on the floor. She could make her thumb touch her wrist. And she did have mitral valve prolapse, which is common in Ehlers-Danlos, but it's also common in the general population. So what did she have? What should we do? Do we keep trying something new and different for chronic migraine, or do we revisit? This next slide, I don't know how well this translates if English isn't your first language, but at the back of the International Classification of Headache Disorders is something called the appendix. It's long and it's detailed and it's very excellent reading. It's also part of the human body. So when you can't localize a headache, it's always a good idea to look in the appendix. So here are just a few comments from the appendix. Spontaneous intracranial hypotension cannot be diagnosed in a patient who has had a dural puncture in the last month. So this is different than the headache that you get after a lumbar puncture, which is usually fixed with a blood patch fairly easily. Oops. What's key to note is that with spontaneous intracranial hypotension, it's not a positional headache, at least not a classically positional headache. We find that when a patient comes in with chronic daily headache and they're complaining of a headache that's about a 8 or 9 when they get to our clinic, if we put them in Trendelenburg while we do our history, very often by the time they finish the history 15 or 20 minutes later, their headache has gone from an 8 to a 2. That can be a good clue because most people with migraine, chronic migraine, put them in Trendelenburg and after about 3 seconds they say, I can't stay in this position, it's making my headache worse. So that can be a very useful element, but I want to stress that what we were all taught in school, that hypotension is almost defined by having this positional headache. I get up, my headache gets worse. I lay down, it gets better. Doesn't apply strictly in SIH. The other thing to note, again from the appendix of the ICHD3, is that not all SIH is quickly resolved by the blood patch the way a spontaneous, the way a a leak from a lumbar puncture responds. And part of the reason for that is most spontaneous leaks come from the high thoracic region, and it's usually anterior. So it's a more difficult patch to perform if you're doing it locally. If you're doing a blind patch in the lumbar region, it may not be as effective. You may have to do several patches. The other thing to realize is these patients often have their leaks because they have a mixed connective tissue problem. And as a result, they may leak, it may repair, they may leak again. So this can have an intermittent presentation. And not all patients with an active leak will have the imaging we'd like to see or the clinical picture. So I would encourage you to raise the question of a spontaneous intracranial hypotension when you have a patient whose diagnosis is not responding to the usual treatments for that diagnosis. Cisternography is not the imaging method of choice with these patients. We use CT myelography in our program. Dr. Shevink down at UCLA, about 500 miles south of us, uses CT myelography. And this seems to be a more appropriate imaging technique. It's not helpful to do a lumbar puncture in many of these patients in order to assess opening pressure. And sometimes the headache that occurs after coitus, and of course we all worry about that being a subarachnoid hemorrhage or a sentinel bleed, very often is a clue if the patient gives you a history of a coital headache and they've been imaged and they don't have any aneurysm. You might want to add SIH to your differential. So this is all in the appendix of the ICHD. What does the ICHD define SIH as? They describe it as an orthostatic headache caused by low cerebrospinal fluid pressure that occurs spontaneously. My clinical experience questions that. I don't think the orthostatic component is as reliable a measure, and it's never been tested. That's just been the conventional wisdom. Typically, it's been accompanied by neck stiffness and hearing symptoms. So tinnitus is fairly common in these patients, as well as other cranial nerve symptoms. And of course, it's supposed to remit after CSF pressure is normalized. What we find is in patients who've had long-standing CSF issues, when we patch them, they go from hypotension to hypertension. So the regulatory system for controlling CSF pressure does not work effectively in these patients, and very often we have to treat with acetazolamide or some other diuretic to compensate for the fact that we've patched them, and that creates other management problems, so you need to be mindful of that. So the diagnosis is any headache that has a low CSF pressure and evidence of leaking on imaging, and it developed in temporal relation to low CSF pressure or CSF leakage, or has led to its discovery. So that's tricky, especially when you have a patient who says, I've had headache for 20 years, I did have episodic migraine in the past, and you say, when did it become chronic? And they say, oh, I don't know, when I was 25. And you say, did anything happen when I was 25? They may say no, or they may say, that's when I fell off the horse, which would give you cause to suspect that there was a leak, or that's when I had the car accident. So keep an open mind to this when you have chronic daily headache of any other, from any other etiology. Closer? Is that better? You couldn't hear me before? Should I start over? I won't. So Wouters Shevink, who is a neurosurgeon in California, has developed additional criteria. I won't read them here, but I think it's useful to note that this seems to be a more reliable and more evidence-based set of criteria for diagnosing intracranial hypotension. When you do look at opening pressure, keep in mind that the patient should be lying down in the lateral decubitus position. There are huge variations in opening pressures, and sometimes you have to start out with the patient sitting in order to find the proper location for the needle, because the pressure is so low you can't get fluid. But when you're going to test for pressure, the patient should be repositioned into the lateral decubitus, legs extended, head at the same level as the needle. This, again, from Woder-Schevink, describes in detail the issues surrounding an opening pressure. But increasingly, we don't use that as a reliable index for someone having a low-pressure CSF headache. How do we differentiate between the post-dural puncture headache and a spontaneous leak? Typically, the leak that you get after a lumbar puncture, it's a single leak. It is clearly positional. It's what we're all most familiar with. It usually responds well to a blood patch. The natural history is pretty clear, and it's usually benign. It's usually pretty straightforward, and we see it a lot in women who are having childbirth, and it's readily fixable. The spontaneous leak, on the other hand, is often at multiple sites. It's often anterior, which makes it a little more difficult to patch. When patients have mixed connective tissue disease, sometimes the perineural sacs start to fill. The root sleeves start to fill as the patient is up and around during the day. So they may feel their best when they first wake up in the morning, and then as the day wears on, the headache gets worse. We usually think of that as being a tension-type headache, but if you have a tension-type headache that actually rises to the level of a tension, it's not likely to be responsive. Only about a third respond to an epidural patch, and it's often very difficult to diagnose. I won't read this whole slide, but this stresses and it gives the references if any of you would like to read further about spontaneous intracranial hypotension. So quickly I want to go over what we look for when we're trying to diagnose this. Typically it's a headache with neck stiffness or pain. There's often chronic nausea and photophobia. There can be cranial nerve signs, often with visual issues, and that's because as the brain starts to sag, it will affect the cranial nerves. There can be intrascapular pain, and it's typically right between the shoulder blades. You can see radicular symptoms, rarely a myelopathy or Parsonage-Turner syndrome. You can see subdural collections, thromboses, and a whole variety of symptoms that are neurologic in nature that don't typically show up with headache. When you're thinking about mixed connective tissue disease, we look for joint hypermobility. I won't read all of these, but these are all features to look for in a patient, and when you find them, you should be suspicious that there is a connective tissue issue. About 30 to 40% of patients with spontaneous leaks do turn out to have a mixed connective tissue problem. So that's probably your strongest hint on examination. These are some of the features you see with hypermobility and lax tissue. There are a variety of MRI signs, which I unfortunately don't have time to go through, but a skilled neuroradiologist is very helpful. The pachymeningeal enhancement and thickening is a common sign. This is what it looks like on MRI. The arrows point to the thickening. The B image is a normal brain. You also see changes around the pons, and that's a very useful area to look. If you look at C, in this case, this is a normal brain, and you see how nice and round the pons is. And then you look at the crowding that you see in the D image. You also see that the cerebellar tonsils are descending. On imaging, this is what it looks like. And here you can see the tonsils sitting low in C and a normal image on the other side. This is the collection you see when you image the spine. This is what it looks like on imaging. Quickly, the management. This is a survey that was done by Amuzigar in 2013, showing the benefit of having a directed epidural blood patch and the best efficacy with neurosurgery when the blood patch doesn't work. The usual complications, unusual complications, you watch for subdural hematomas, hygromas. Herniation is extremely rare, but it can happen with hypotension uncorrected. So that's my cautionary tale, and I hope you'll keep in mind that SIH can be a game changer for many patients who for years have had headache that has responded to nothing. So keep it in mind. We've found it to be a really rewarding activity in what's often a very frustrating area of medicine. Thank you.
Thank you, Professor Cohen. We keep the questions till the end of the session. And now, Professor Stephen Silverstein from the USA will talk about update in migraine treatment.
Thank you. Thank you for inviting me. And what I'm going to do is start with where we are now and where we might be going. And just some basics. No matter what type of headache you're talking about, you need to make an accurate diagnosis. The ultimate goal is headache relief. But I can tell you when patients come to us, they always worry that something bad is going on, and they want to be sure that their complaints are being taken seriously. When we talk about headache treatment, it's important to differentiate between acute and preventative. As you'll be seeing later, the line is blurring. And some of the newer treatments that we're dealing with both work for acute and preventative treatment. So we're going to have to figure out a hybrid term in the future. And we're talking about migraine treatment. It's not acute or preventative or pharmacologic or behavioral. It's all of them. You need to take these into account when you look at the patient. Most patients need acute treatment. Only behavioral, there's nothing more to tell them. They get some adequate sleep and exercise. And about 40% need prevention. There are two subsets of migraine medication. Non-specific, which are good for pain throughout the body, and specific, which is good for head pain. And I do not say migraine specific because they work for cluster headache and the headache of subarachnoid hemorrhage. What are the basic principles of acute treatment? Treat early. All of the studies have clearly shown the earlier you treat, the better the result, probably because of the presence and development of central sensitization. Always use non-pharmacological treatment. Rest, cold compresses. If it's noisy, get out of there. And almost always you should use acute medication. And one of the secrets is to match the intensity. What are the recommendations from the American Headache Society and the American Academy of Neurology? Use migraine-specific medicines first line for all patients with moderate to severe headache and those who respond poorly or inadequately to nonsteroidals or combination medication. Remember, the biggest mistake we make is to give a non-oral route. Many patients have gastroparesis, delayed gastric emptying. Going through the oral route means it's never going to get in there. Have your rescue medicine and guard against medication overuse headache. So what's next? That's where we now exist. Where are we going? What are the receptors and what are we dealing with? I'm going to be talking about the serotonin 1F receptor, which is part of the trilogy of the triptans, and I'm going to start to talk about the CGRP receptor. I'm not going to talk about NMDA or the ASIC receptors, but that will be coming. You heard a lot about CGRP at this meeting. You heard about the fact it's in C fibers, that it's released in the central nervous system. Beta CGRP is mainly in the enteric, that's the gut neurons. They actually behave the same way, but they're made by different routes. To reiterate, CGRP is a neuropeptide. That means the peptide in the nervous system. We now know it's in C fibers. The receptors are on the A delta in the mast cells. They are released with glutamate by activated trigeminal ganglia, and they're involved in vasodilatation, mast cell degranulation, sensory transmission, but we have no idea in the world when you infuse it how it triggers the migraine headache. And you saw this before, and this is important. There are really two CGRP receptors. You heard earlier about the canonical CGRP receptor, which consists of the calcitonin-like receptor and the RAMP1. CGRP has as much affinity for the amylin-1 receptor. We don't know what the amylin-1 receptor does, but it's something to think in mind as you start to have antibodies. The first antibody is an antibody, and I'll talk about that against the receptor. The other antibodies are against CGRP itself. So in one case, you're getting selective blockade of the canonical receptor, and the other, you're blocking both receptors. So the evidence you've heard before. CGRP infusion triggers migraine. Levels go up during a migraine attack. If you give a triptan, they go back down. One of the mechanisms of action of triptan is to block CGRP release, and CGRP receptor antagonists block CGRP, inhibit pain transmission in the absence of being direct vasoconstrictors. There you have CGRP and glutamate coming out, going to the receptors. You give a GPAN, it blocks it, and that's how they work. The first class of drugs to be developed in the CGRP family were small molecule CGRP receptor antagonists, such as talcagipant. They did not constrict blood vessels. They had the same side effect profile as placebo. They may not induce medication overuse headache, and some people have suggested they may work when triptans failed. This is an old study simply showing that talcagipant, one of the early drugs in development, worked and beat placebo and was almost as good as zolmitriptan. But what was the problem? They worked, but the development was discontinued because in some of the studies there was elevation of liver function tests. And therefore, for a time, the entire field was abandoned. And the fundamental question is it blocking CGRP that causes liver problems? Or was there something about the design of the molecule that did it? And I think we now know the answer. There are now 4 CGRP small molecules in development: ubrogepant, atogepant, rimegepant, and BHE by both Allergan and Biohaven. Just to show you the data, I'm not going to go into the details. This simply shows in early studies that it works. And if you look at the ubrogepant acute migraine study, the data suggests it makes the primary and secondary endpoint. But what's important about these drugs is the side effect profile is very similar to placebo. If you look at rimegepant acute treatment phase 3 study, very similar data. They beat placebo in all the endpoints. And the major issue with these drugs, the major benefit, is the side effect profile is similar to placebo. So now we have the story of CGRP, blocking CGRP. Original drugs were discontinued because of toxicity, and new drugs are now being developed without that problem. The second receptor site is the serotonin 1F receptor. Triptans go to the 1B as in boy, D as in David, and many to the 1F receptor. The selective receptors don't go to the 1B or the 1D. They're not in the vasculature, therefore they have no vascular vasoconstrictive results. And in some of the models of migraine, it was shown to be effective. What is the localization? Just to reiterate, if you look at this, the B receptors are on B for blood vessels. The nerves have 1B, D, and F. And what you want to do is find a drug that doesn't work here, that works here, so you don't have the side effects. One of the interesting findings that I just became aware of is a lot of the older studies on coronary vasoconstriction were done in the proximal part of the coronary artery. And if you look at it, this is the curve of sumatriptan compared to lasmiditan. If you look at the distal coronary artery, much more profound effect compared to lasmiditan. So it tells you two things. The triptans are more potent cardiac vessel vasoconstrictors, and this class of drug doesn't. So the concept is that the triptans work by blocking the release of CGRP, nitric oxide, and glutamate. The gepants selectively block CGRP. Lasmiditan blocks CGRP, nitric oxide, and glutamate, but since it doesn't work on the blood vessels, it's not vasoconstrictive. Does it work? There are phase 3 placebo-controlled double-blind trials that have been published in the process of being published. It shows in preliminary data looking at the primary endpoint, roughly 30% versus 15% for pain-free, which is higher than the results with the oral gepants. And there's a concept of what symptom of migraine, other than head pain, bothers the patient the most, and it won on that endpoint. The crucial problem with the lasmiditan as compared to the gepants is the side effect profile. And many of the patients had dizziness and or vertigo. And the reason that occurs is that there are selective 1F receptors on the vestibular system, as is CGRP. So it's activation of the 1F receptors in the vestibular system that leads to this adverse event. Let's now move on to prevention. We estimate in the United States and perhaps throughout the world that 40% of patients with migraine are eligible for prevention, but only about 13% get it. When should somebody have prevention? These were the guidelines we wrote a long time ago. Where did they come from? We sat in the room and agreed. There's no scientific basis for this, but we have some. If migraine interferes with the patient's daily routine or activity, despite acute appropriate treatment, the evidence for attack frequency greater than 1 a week has come from Richard Lipton's data showing frequencies above that lead to chronic daily headache or chronic migraine, as it is now called. If the acute medications don't work or overused, patient preference. If a person has an occupation where having a migraine attack would be disabling, if you're a neurosurgeon or an ophthalmologist, you don't want to go blind from your aura while you're taking out somebody's cataract or pituitary tumor. Special preferences, hemiplegic migraine, basilar migraine, migrainous infarction. This is the data from the guidelines from, I guess they're 6 or 7 years old, showing based on scientific studies what are the ones with the best evidence, and that would include topiramate, divalproex, the beta blockers, some of the anti-amitriptyline, venlafaxine. I think the important point I always make about guidelines, the absence of evidence doesn't prove they don't work, and if the drugs have not been studied in modern trials, they're not going to get the highest level of evidence. What are the basic principles? Now, this is what we used to say. Start with a low dose and increase slowly. We're going to throw that out with the antibodies. You start with a high dose and you don't have to increase it. You need to wait, and I'll talk about that in a minute, whether it's the antibodies or something else. You need to make sure there's no overuse, evaluate therapy, and avoid pregnancy. How do you decide what to use? What kind of migraine do you have, with or without aura? How effective is the drug? Scientific evidence and your clinical experience. We've all seen studies, we tried the drug, it didn't work, and they said, my God, where did they do that study? How safe is it? What else is going on? And what is the patient's preference? I love this quote. The right dose differentiates a poison and a remedy. Remember that. What are the comorbidities that implicate treatment? These are disorders that are more common in patients with migraine, angina, stroke, bipolar disease, depression, epilepsy, as you heard about today. irritable bowel, delayed gastric emptying, allergies, asthma, and obesity. These impact treatment choice. So, pick the best drug for the disorder. We used to say do 2 for 1. If you're depressed and have migraine, give amitriptyline. Nobody believes that anymore. Don't give a drug that'll make the other disorder worse, and vice versa. Beware of drug interactions, and pay attention to women of childbearing potential. You've heard a lot today about the antibodies, and I'm going to skip some of this because I'm getting late, and you heard about it. One of the things I just want to reiterate is all of the antibodies are IgG, and they have been genetically engineered to change their properties so that part of the antibody that would interact with the immune system is gone, and they don't interact with the immune system. In terms of naming, I think you've seen this before, but just to reiterate, all the modern antibodies are humanized or human. You can tell if there's a zoo, that means it's humanized because the zoo is where animals are, and U is for totally human antibodies. How do they work? Antibodies target and destroy foreign pathogens. Therapeutic antibodies can actually destroy target cells or interfere with their function. The direct mechanism is for the antibody to bind to the receptor or the ligand. The indirect mechanism is as follows. It works through an immune cell. So there are antibodies that can actually attach to immune cells and actually target and kill cancer cells. What's the difference between a small molecule and an antibody besides size? Small molecules can be given orally, antibodies can't. Small molecules can pass the blood-brain barrier, antibodies can't. Small molecules last hours to days, antibodies can last for a month. Small molecules are made by the chemist. Antibodies are made in tissue culture. And what are the benefits? There are no toxic metabolites. It breaks down to amino acids. Drug-drug interactions are of no concern. They can last for a month. There's no off-targeted toxicity, and the tolerability is quite good. At this point in time, there are 4 antibodies in development or approved. Eptinezumab or Enyumab, which is now approved, Fremenzumab, which is approved, and Galcanezumab. They're all different. The first is an IG1, an IG2, a 2A, and a humanized IG4. Although they have different backbones, with genetic engineering, they're more alike than different. So, I'm going to do this in alphabetical order to be fair. Eptinezumab is unique in one way. Unlike all of the other antibodies, it's made in yeast. And what that may mean, we're not sure, but the sugars on the antibody may be slightly different. Enyumab is different from the other group because unlike them, it goes directly to the receptor as opposed to CGRP itself. It binds exquisitely to the receptor, and you'll be hearing things about somebody says, well, my drug binds, mine doesn't. They all bind tightly, and I think the differences are minor. The third antibody is Fremenzumab. This is an antibody that goes to the CGRP itself. It's different in the sense that it can be given every 3 months or monthly. And lastly is Galcanezumab. This is another antibody to CGRP itself. Instead of showing you the individual data, what I thought I would show you is an overall look at 50% responder rates for all of them. And if something is high, that's because the placebo is high. If something is low, that's because the placebo is low. But if you look at the therapeutic gain or the difference, they're more similar than different. All of them work. All of them have side effects similar to zero, placebo. If you look at the results from the chronic migraine study, same thing. The first is the highest, but the therapeutic gain is 14. But look at the lowest at the end, it's 1838, it's 20. So whenever the results are lower, the placebo is lower, and that's a function of the clinical trial, not the effectiveness of the drug. If you look at 75% response rates, you're going to see the same thing. all the drugs are equal. If one goes above the line, that's because the placebo response rate is a little higher. If one is way below the line, it's because the placebo response rate is lower. Just look at that, 28 versus 36, that accounts for it. So you cannot, in general, compare one trial to another unless you have them in the same trial. What can we conclude? Antibodies to both CGP receptor are effective, they're safe, there are few side effects, except for injection site reactions and perhaps constipation. Last minute, I'm going to be talking about onabotulinum toxin and how it works. It consists of a heavy chain and a light chain. The heavy chain transports it intracellularly. The light chain is the enzyme. It's safe, it's effective, and it works. But how does it work? How does giving a drug which we've used for years for muscle paralysis work in migraine? We know it has a sensory effect. It blocks the release of neurotransmitters. It has a transcranial effect because the same nerves on outside the head go inside. It inhibits phenolpalatine ganglion activation. And what can we say? Recent new work. If you produce cortical spreading depression, which you heard this morning very elegantly, you can actually activate C fibers and A delta fibers. Let me do it this way. C fibers and A delta fibers. The C fibers contain CGRP. The A delta fibers contain the receptor for CGRP. Oops, what did I do? So, it looks like Botox works on the C fibers and stops it from interacting with wide dynamic range neurons. It looks like the CGRP drugs interact with the A delta fiber, which has input to both the wide dynamic range neurons and the high threshold or neurons. This says to me something potentially extremely interesting. I believe, and the studies are now underway, to prove that these drugs are synergistic. Now, in the United States, there's an organization called ICER, which analyzes data, and they published this graph. And the only reason I'm showing you this comes directly from them. And they looked at the difference between placebo and active drug, comparing all of the antibodies, comparing Botox and topiramate. And the point I'll make is they look similar, but this data is intentionally misleading. Because what they do is assume for the sake of argument, in real life, the drug worked 100% of the time, and the placebo worked 95% of the time. They wouldn't like that drug. But what if this was a disease that had, if you got it, you'd die? So this drug would be 100% effective in preventing death, but they don't look at it this way. The other point is they look at all comers, they don't look at winners, and the important issue is if you give a drug to somebody and it doesn't work, you're going to stop it. So in real life, you need to look at how effective the drug is, not how effective it is compared to placebo, and go from there. Thank you.
Thank you, Mr. Stephen, for this nice presentation. الكويشن في الآخر. الكويشن in the end of the session. Now I'm happy to introduce Dr. Ramez Reda Mustafa, who is the moderator and generator of this conference, and thank you for this big effort for hoping successful conference. The subject for Dr. Ramez: treatment in migraine.
Thank you, Mr. Chairman. It's really very challenging to speak after all the very eminent professors and the stars of migraine, really, and headache. But I'll be taking an approach that's more simple, more geared towards the younger generation of neurologists, whom I must say are very impressed with the gathering of all the neurology experts and the migraine experts. So I'm just going to speak briefly about chronic migraine, its definition, the available treatments, and I'm going to focus on who responds to what kind of treatments should we tailor to the individual patient, and whether there are any predictors of response and any thing that would guide us towards choosing the right medication for the right patient. So as you probably already know from the lectures yesterday and today, chronic headaches in general are very common. About 5% of the population, about 2% of the population have chronic migraine in particular. And the rest are other types of chronic headache, just chronic tension type headache. And because tension type headache is common in the population, of course it's common as tension type headache is common in the population. But in our clinics, what you've seen several times in the past 2 days from Professor Peter Goldsby and others is that in your clinic you will only see chronic migraine patients. You don't see chronic tension type headache a lot in your clinics, mostly because the migraine patients are the ones who suffer. So chronic migraine is defined as headache on more than 15 days a month for at least 3 months. And of course we know that 15 days is just an arbitrary line in the sand, as Peter Goldsby would say, but essentially it means that the patient has more headache days than in the month than headache-free days. And we know that there are several medications for preventing chronic migraine, and the list does not end here, but this is one list with over 30-40 drugs. Some of them are effective, some of them are not very effective, some of them are buried with side effects, some of them are very mild but not effective. The most common ones are beta blockers, heavily used. They are evidence-based. We have, of course, things like calcium channel blockers, flunarizine, cynarazine, antidepressants, all the traditional drugs. But you would be surprised to know that only a limited number of them are evidence-based. Most of them have, out of experience, people have used them, but the ones who are evidence-based are very few, mainly valproate, topiramate, and gabapentin in the anticonvulsant class. In the antidepressant class, only amitriptyline, fluoxetine, and tizanidine, which tizanidine, of course, is the muscle relaxant as well. And recently, in the past few years, the ACE inhibitors. So out of the prophylactic medications, the oral prophylactic medications, only a few are actually evidence-based, and the evidence is not very strong for the rest. For propranolol, the traditional anti-migraine, anti-chronic migraine, it produces about 40 to 45% reduction in chronic migraine. Amitriptyline, again, half of patients respond to it. For valproate, it's pretty similar. About half of patients respond to it as well. And even for topiramate, with all its importance, but still, you find that about half of your patients would respond to topiramate favorably. And you might even argue that patients with migraine are more sensitive to topiramate related side effects. As we said, candesartan, of course it's Atacand, as it's called. The response rate is similar, but maybe the profile of side effects is more favorable. Botox, of course, is more tolerable, though some patients would not accept it. But again, Botox is effective, and also in a certain number of patients, which is also about 50%. For the CGRP, it's not more effective than, much more effective than other treatments, but it's much safer. As we've heard, these are the old names, of course, while the trials were going on for the anti-CGRPs. Anti-CGRPs are very, very safe. They promise a lot. They're probably going to be used a lot, but and the number needed to treat is about 4, which is good, very good. Number needed to harm is 20, which is much better than the rest of the treatments we know. The thing is, with all these treatments, how do you choose the right treatment for your patient? You have a patient and you need to select one of these drugs or some of these drugs to treat him. We've always used the traditional choice of drug, like the proven effectiveness of the drug, the doctor's beliefs about the drugs, the adverse effects of the patients, and of course, if the patient prefers some sort of therapy in particular, and based on comorbidities. One of the most frequently overlooked things is the headache profile itself. So comorbidities, as Professor Silberstein was just saying, that patients with migraine have a lot of comorbidities, and it's often that the patient has something in addition to their migraine. And this often guides your choice of treatment. But what I would argue is that it's also the headache profile, the phenotype of the headache itself should be important in selecting the right treatment for the right patient. At the moment, migraine is still being treated as, for example, epilepsy in the past, in the very, very past, where it's not one disorder. We say chronic migraine, there are certain types of migraine, certain versions of it. So just like what happened in epilepsy, where the more we know about epileptic syndromes, about types of epilepsy, and then we know that certain medications help in certain types of epilepsy, and in depression and in stroke and so many other diseases, where the more we know about the phenotypes and the supporting genotypes of these types, the more we are better at selecting the right treatment. So I've gathered some evidence on how the phenotype of migraine might help with selecting a certain drug. Of course, the prototype example in headache in general, not in migraine, is that some types of headache are extremely responsive to indomethacin. They're even called the indomethacin responsive headaches. So the classic example, of course, like paroxysmal hemicrania and hemicrania continua. So this is just an example of a type of headache that if you identify it clinically, then you know that this treatment will be very, very good, whereas other treatments will not be as good. There's some papers in the literature that would classify migraine patients in several ways and trying to use this classification to select treatment. So for example, in this example, we see that they've divided migraine into 4 types: stress-related, where there's a strong adrenergic component, and the claim would be that propranolol and beta blockers would help in that type. Patients who have a lot of mood, sleep disorders, maybe that's a serotonergic component, and in that sense, serotonergic drugs or drugs that act on serotonin would be helpful. And the same for menstrual-related migraine, where we know that estrogen and hormonal treatment helps. And if there's nothing, so it resembles tension type, then maybe muscle relaxants would help. So that's one type of classification. Also, there's some evidence that some migraine symptoms might be related to dopamine, and we've tried that with our patients many times, where if the patient symptoms are dominated by nausea and vomiting, we find that metoclopramide would often help them. If it's migraine with cluster features, autonomic features that are very prominent, maybe topiramate, because it also helps in cluster headache, maybe topiramate and valproate would then help. Some also studies have shown that patients who have aura might respond to calcium channel blockers maybe better. For Botox, for example, after Botox we knew that it's effective. There were several trials to try to find who would respond better to Botox, how to select a patient for botulinum toxin. So in some studies, they found that predominantly unilateral location would be more responsive. Patients with allodynia would be more responsive. Patients who have tenderness all over their head would be more responsive. Ocular types might predict, and elevated CGRP level. If the patients have elevated CGRP level, it seems that they might benefit more from the botulinum toxin injection. Also, it's been shown that patients with imploding headache, as opposed to exploding, and this is also a phenotype of headache, patients who seem to have describe their headache as imploding seem to respond very well, whereas those with exploding do not seem to respond very well. There's also some studies on the predictors of a negative response, so when to stop your patient from taking a certain medication. So for topiramate, a very chronic headache and poor response to previous divalproex in particular would predict a negative response. And for Botox, well, headache more than 30 years, but that's the same for all the medications, I think. Finally, even for local procedures like greater occipital nerve block, which is very useful in cluster headache, it's also very useful in migraine, and may be effective in migraine that has cluster features, but actually it might be effective in most types of migraine. So again, there have been several trials to find what are the predictors of response to greater occipital nerve block, and it makes sense that if the patient has tenderness in the head, and if a particular nerve on the right or the left, the greater occipital nerve, is tender, then the response to treatment is better. These predictors are not consistently found, but maybe because the current evidence shows that it might not be necessary to have the tenderness to get the response. So in conclusion, what I would say is that patients with migraine are not all the same. I think we need a phenotypic classification of migraine, and it's much needed. A classification that would help identify subtypes easily in the clinic, and that would be supported by imaging features, biomarkers, genetic tests, and that helps in predicting the response. So I believe that this phenotypic classification, supported by imaging, biomarkers, and genetics, would help us identify which treatment fits which patient, so that the roughly half of patients who do not respond very well to any single treatment can then be, this gap can be then be covered. Thank you for listening.
Many thanks, Professor Dr. Rames, for this conclusive lecture, and many thanks, Dr. Rames, for organization, for you, and for Professor Dr. Osama for first conference of headache, successful first conference headache. Thank you much, and
thank you very much.
We will postpone the question at the end of the session, and it's nice to introduce Dr. Hatem Samir for next lecture.
Yeah, Dr. Hatem has apologized because he had this personal incident, and I think Yusufa Maiga will complete the session.
Okay.
Thank you.
So we will introduce Dr. Yusufa Maiga for epidemiology of migraine in sub-Saharan Africa.
Good afternoon. I'm very happy to be here. I want to thank all the organization committee. I'm from Mali, a French country, so English is not my common language, or I will try to do my best. I want to talk about epidemiology of migraine in sub-Saharan Africa. First, we will talk briefly about the concept of sub-Saharan Africa to clarify these concepts, and after we do review on migraine. You see here, sub-Saharan Africa. Sub-Saharan Africa refers to an artificial geographic delimitation with specific socio-economic realities and extremely different environmental setting from one country to another. Nevertheless, a common ground exists between these countries justify our analysis and this sub-regional scale. Sub-African Sahara count over 618 million inhabitants, with more than half aged 50 years old or younger. Most of the population live in rural area. Massive migration from the rural to the urban zone results of the overpopulation of the sub-urban zone with poor health condition and services. Life expectancy was 48.5 years, and the mortality rate in children less than 5 years was 164.2 in 2002. Only 46.4% of the population urban have access to drinking potable water, and 55% have access to the appropriate hygienic equipment. The demographic growth is more and more important in Sub-African Sahara. The economic situation, the economic growth rate is climbing. So here you see, according the global growth on the continent is 2.6 in 2070. It is expected to be 3.2 in 2080 and 3.5 in 2090. A lack or scarcity of data on migrants does not allow an analysis of the sub-regional level or even at the country level. Data are different from the sub-Saharan country and the northern country in the continent. So now, let's go to do the review of migrants in the sub-Saharan African region. Headaches are common, the most common medical condition worldwide. Tension tape headache and migraine are respectively the second and the third most prevalent disease globally. In sub-Saharan Africa, few prevalent studies of primary headache have been carried out in selected subpopulation. The burden of migration hasn't been accessed yet. Epidemiologic studies in sub-Saharan Africa are few and old, witnessing the lack of interest in migrants and the difficulties of such studies. Migrant studies in sub-Saharan Africa are hardly accessible to the scientific community in the sub-Saharan Africa. Migrant prevalence widely varies between 3.1% and 26% in the literature. Study population of diagnostic criteria are both very diverse. Migrant articles are often published in the national or regional journal, not indexed in PubMed or Medline. Migrant studies in sub-Saharan Africa are not valuable in research method. The bias in the selection of the patients, the disparate in working definition of classification criteria, the non-standardized approach in data collection. In recent years, prevalence rates are become consistent between many studies using the EHS criteria. What is the International Headache Society carry out a large-scale epidemiologic study adopting a uniform approach across sub-Saharan Africa. Now, analytic epidemiology on migrants in sub-Saharan Africa. The first studies, these studies was the first studies. The first general population based survey to estimate the prevalence of migraine headache in Zambia. And is the first study in sub-Saharan Africa. Prevalence of migraine was 23.3 with a female predominance. This is the second studies was in Ethiopia. This studies was the second in the global campaign against headache in sub-Saharan Africa. The prevalence was 70.7 and 20.6 for tension type headache. This is our study in Mali. It was a prospective cross-selection descriptive and analytic studies which lasted 16 months from May 29 to July 2010. Sample size was 733. The criteria of ESH and the interdisciplinary research group on migraine were used for diagnostic of migraine. The over prevalence in our study of migraine in school was 17.3. The headache prevalence among students was 20%. The prevalence by gender was 23 in girls versus 14.8 in boys. These studies in Nigeria, the prevalence of headache was 23.7. Age and gender as a migraine risk factor. Migraine prevalence studies in infants are rare in Africa. Migraine prevalence was at its peak in patients aged 18 to 40 years old and declined at older ages. Female predominance in migraine was confirmed in all the migraine studies with a sex ratio 1 versus 2 for female. Socio-demographic ranking and residence as a migraine risk factor in Africa. Migraine in Africa is an urban disease. High socio-professional ranking is most associated with migraine. Heritability and migraine. Familial history of migraine is the most powerful, strongest, and most consistent migraine risk factor from the African studies. GWAS found genetic implication in migraine. Comorbidities of migraine. Comorbidities of migraine. Numerous African studies focused on the association between migraine and comorbidities. Headache are low specificity symptoms than that accompany many neurological diseases and non-neurological pathologies in Africa, especially endemic infections, pathologies in Africa. Example, malaria, meningitis, encephalitis, cerebral abscess. In the absence of the clear diagnostic criteria, migraine can be over-diagnostic in excess or under-diagnostic by default. Migraine and psychopathology. Most the studies on the topic are from Ethiopia, with very few in the rest of sub-African Sahara. Tobacco in Africa, no association with migraine. Migraine is strongly associated with unipolar psychiatric symptom. Anxiety, migraine patients are elevated risk of severe anxiety. Stress is pronounced in migraine patients. Migraine and depression in Africa. Migraine patients are 3x more susceptible to depression as compared to the general population. Depression is moderately severe in migraine. Depression is severe among patients with migraine with aura. Early screening and treatment should be done. What about migraine and suicidal behavior in Africa, Ethiopia? Migraine and suicidal behavior in sub-Saharan Africa. Problem in these studies, migraine was associated with a suicidal risk 2.7x more as compared as control. The suicidal risk exists with or without depression. What about migraine and epilepsy in Africa? Few data exist on the association between migraine and epilepsy in Africa. None of the existing studies have used rigorous methods taking into account the ESH criteria of epilepsy and migraine. The ideal working on the topic has not yet done due to the importance of this pathology in sub-Saharan Africa. Migraine and vascular pathology in sub-Saharan Africa. High blood pressure. Many studies reported the association between high blood pressure and migraine. Cerebral infarctus, several case reports on cerebral infarctus has been published. Transition ischemic stroke. Data exists on the association between AET and migraine. Impact of migraine in sub-Saharan Africa. Migraine decrease the quality of life in sub-Saharan Africa. Migraine leads to handicap in 90% of patients in Africa and worldwide. Most of the handicap are due to the comorbidities, anxiety, depression, sleep disorders in African patients. Economic burden of migraine is either due to the direct cost on the treatment or loss of productivity or days without work. In conclusion, migraine epidemiology in sub-Saharan Africa. The African Literature Review confirmed the importance of migraine in sub-Saharan Africa. The epidemiologic pattern of migraine in sub-Saharan Africa is globally superposable in the rest of the world. Female predominance, comorbidities, young age of the patients, negative impact of the quality of life. The ESH criteria allow to reduce the variability in migraine diagnostic from African studies. It is important to conduct a large-scale epidemiologic studies in migraine in sub-Saharan Africa. Thank you.
Well, we had a very rich session in the afternoon, and we had very eminent professors in the field of headache medicine with us, thanks to the organizing committee and the chair of the conference. And now we have some time for questions, please. Professor Cohen?
Yes, this is a question for Rob Cohen. You started your talk by a case presentation, and then you spoke about SIH. Whatever happened to that patient?
It's a great question because I never finished that story. It's tough to talk in just 15 or 20 minutes. So this was a lady who had been significantly disabled for 20 years. When we re-examined her and felt she had a reasonable case for a leak, we imaged her with CT myelography and found she had a small leak in the high thoracic spine, and it was anterior. We did a directed directed patch at that level. When she got off the table, she said it was the first time she was headache-free in 20 years. It was something we don't usually hear in headache medicine. She did well for about 3 months. And this was with the first patch. She did well for about 3 months, got back into gardening, fell, hit her head on the wheelbarrow, and the whole thing started over again. We patched her a second time without as dramatic a result. Then we went in a third time with a fibrin patch, and she has been back to episodic migraine 1 or 2 days a month since. So she did extremely well. And I can't stress enough how rewarding that is when you take someone who's been chronic for so many years and set them free. Yes. So our protocol is to start with an MRI of the brain and full spine. And obviously, if we see extraaxial CSF on the spine, or if we see obvious stigmata, and I didn't have time to go into it, but there's some very sophisticated analytic tools having to do with the angle of the pons to the maxilla, the mammillary bodies, and it gets really complicated, but the neuroradiologists have this. So if we see stigmata on imaging, that's enough for us to go in with a blind patch, even if we can't find the extraaxial. But very often what we see is just lax tissue. So when you image a patient who's been lying down, their imaging looks fairly normal. But if you image them in the late afternoon, the sleeves of the exiting roots are all dilated, and it's almost like the CSF is pooling during the end of the day. So when you do, that's the reason a tap is not so helpful. When you do this, when you do a tap, it's a snapshot. And CSF varies so much during the day in terms of pressure and volume that it's very difficult to use that as your sole indicator. But we always image, starting with MRI, and then we do CT myelograms.
Well, I have two questions, please. It's me.
Oh, hello.
I have two questions. How often do you diagnose spontaneous intracranial hypotension prevalence?
So I don't have statistics on it yet, but I can tell you that we started kind of picking this up ourselves after a talk by a colleague from Duke University, also in America. And once we started looking, it's sort of like you become a barber and everyone needs a haircut. So the more you look, the more you find it. And we find that many of these very difficult patients, particularly those who have some evidence of connective tissue disorders, have this as the primary issue. We don't have statistics on it yet, but I can tell you in the last 5 years, we've gone from one, that I'm aware of, one specialized clinic for SIH. I now know of 5. I think that Dr. Silverstein's clinic is doing a lot of work. So are we. Deb Friedman in Texas has a dedicated clinic now. So I think it's something that's very underdiagnosed, underrecognized. But we're very backed up. We've got about a 3-month wait now for that clinic.
You don't mean that it is a differential diagnosis for chronic migraine from the title of the...
I'm sorry?
Is it a differential diagnosis, or is it
I think
association with chronic migraine, or it's something different?
I don't think it's, I mean, I think when you've got a condition like migraine that is so ubiquitous, so common in the population, you're going to have patients who have migraine and a brain tumor, migraine and a leak. So I think it can be a little deceptive. Right now, we've incorporated screening questions into all our first visit, when a patient comes to us for the first time, we've incorporated questions to raise the question of whether or not they might have a leak. We do a 48-hour flat test, so we ask the patient to lay flat at home for 48 hours and monitor how their headache changes. We often just put the patient in Trendelenburg for 20 minutes, and sometimes that's enough to raise the level of suspicion. But we're doing it mainly in patients who have probably been misdiagnosed with chronic migraine and not responded well to therapies.
Did you try any medical treatment for these patients as a test or therapeutic test?
Usually, all of the usual suspects have been tried before we see these patients. So they're patients who haven't responded to any therapies effectively, which would be consistent with a missed diagnosis. So these are patients who've already tried botulinum toxin and topiramate and nerve blocks and things like that. But in terms of medical therapies, sometimes we'll see a rebound hypertension after we do the block, and we usually treat that pharmacologically with a diuretic. But I'm not aware of a treatment. Now, patients with Pott's disease and leak, which is a common combination, sometimes will do better if you address the Pott's disease, the postural orthostatic hypotension, or autonomic instability. And that can be sometimes addressed with pharmacy, but I'm not aware of anything that will help this SIH pharmacologically.
Last thing, excuse me. How do we explain the meningeal changes on MRI? Why?
The changes on MRI?
Meningeal changes.
Oh, the meningeal changes. So it probably comes down to basic physiology. You have sagging, you know, because there's not enough pressure. So you have some leaking of fluids. You get inflammation and irritation.
Irritation, chronic irritation.
Yeah.
Thank you. Any more questions for Professor Cohen? And now any questions for Professor Silberstein? Professor Weil?
What about the explanation of constipation that occurred with monoclonal? And if it occurs, we stop the drugs, or what do we do?
Could you repeat your question again? I'm sorry.
What about the explanation of constipation that occurred with monoclonal?
With what? I'm sorry.
Constipation, side effects of constipation.
Oh, sure. That was an amazing finding, and I dug into it. The first thing I found is that there is a patent for the use for the antibodies for the treatment of diarrhea. The second thing I found out is that people who get infused with CGRP to induce a migraine develop diarrhea. How? There are two sets of neurons in the gut, the extrinsic neurons, which predominantly contain alpha CGRP, and the intrinsic neurons, which contain beta CGRP. These are the neuronal networks responsible for gut motility. So they're resolved in peristalsis. If you block the receptors, it inhibits peristalsis and produces constipation.
Can I ask you a question, Dr. Silberstein? This is here.
Oh, sure.
Okay. My question is clinical scenario. With monoclonal antibodies now we're just starting to use, and as you have more experience than us, if I have a chronic migraine patient with rebound that been on more than one medication at the same time, and allodinic, tried infusions for a while, improved, then got worse, try Botox for a couple of times, and then she came back and we could not taper down the medications. So now I'm stuck with a female, with a patient, mostly female, that is a chronic migraine rebound, failed Botox, failed infusions, and I want to give a try for monoclonal antibody. Do I just do the monoclonal antibody and taper down immediately the medications, or I do multiple therapies?
Basically, the people we've been treating are exactly like that. We've up to several hundred. And our philosophy is that if you do two things at once, you never know what's going to happen. So we add the monoclonal antibody because there are no drug-drug interactions, and the safest thing to do is do the antibody, but you got to give it 3 months. We've actually shown, if you look at non-responders at 1 month, a significant number of them will respond 50 or 70% if you go out 3 months. 1. So I add the antibody, 2, go through a couple cycles, and then reevaluate them. And if they're doing very well, then you can make a decision to start eliminating other drugs. Some people do it differently, but my preference is to not do two things at the same time. Say the drug is partially effective, you stop it, you put them on the antibody, they get worse. You're not going to know. If it's toxic or side effects, that's a different issue.
Thank you.
If any more questions?
Thank you, Professor Silberstein, for your presentations and presence. I'd like to ask you if there is any predictors that can tell us whether this patient is going to respond for the new class of medications, CGRPs, like the indicators or predictors for the product's response?
There is one study that's been done. Masudai Shina in Denmark has looked at people in the trials who responded and didn't respond. And what he found is that those who responded, all of them got a headache from CGRP infusion. Those that didn't respond didn't. So at least we can look at that. But the question is up front, I don't know of any simple way of saying who's going to respond and who's not going to respond at this point in time. And probably the simplest way to do it is just try it.
Thank you.
Two commonly asked questions are, to me, I've heard it, if somebody is on a monoclonal antibody for a rheumatological disorder, can you mix antibodies? And the answer is absolutely yes. The only time you have a problem is they have similar overlapping mechanism of action. Second question that's commonly asked is about pregnancy. Since these antibodies have a half-life of about a month, it's safer to wait 4 or 5 months before a woman gets pregnant than most of it's out of the body. Thank you.
Any more questions? So it's the end of the session, and now everyone with Dr. Osama.
So we come to the end of a long day. Thank you very much. We expect to see you all at 8:30 here in this room for the dinner. Okay?